At least it wasn't like a couple days. Ready? Good morning, remote attendees. Doing a sound check. Brian Alston, can you hear me?
Yes.
Excellent. Thank you very much.
to call the meeting to order, and Secretary, the call the roll of attendance.
Director Kim? Director Sorrell is absent. Director Stain is absent. Director Webster-Cross? Present. Chair Bott?
Present.
You have a quorum.
Thank you. Good morning, everyone. Our next regular meeting is Friday, February 20th at 9 a.m. I'd like to ask Secretary if any speakers registered to provide virtual in-person testimony or sent written testimony to be included in the record.
We did not receive any registrations nor any written testimony.
Thank you. We'll go to our action items next. Appointments, reappointments to Georgia Department Division Chairs presented by Dr. Lawrence Smith, Chief Medical Officer.
Good morning, Director.
Good morning.
This morning I have two to present for reappointment for division chairs and medical staff of John H. Schroeder Hospital of Cook County. Dr. Wilberto Nieves Nira for the Department of OB-GYN, Chair of Division of Gyn Oncology. Dr. Nieves Nira graduated from the University of Puerto Rico in 1991, completed residency and fellowship at Emory University in Atlanta, at the National Cancer Institute in Bethesda, Maryland, and University of Miami, Florida. First joined CCH in August of 2019 as an author and a lecturer, and this again is a reappointment. And the next candidate is Dr. Manhel Kilfe for the Department of Pediatrics for the Chair of Division of Neonatology. Dr. Kilfe completed medical school at Salah Aden University in 1988, has done training at Etihad Hospital, Michigan State University, and University of Illinois in Chicago. He first joined CCH in August of 1999, and again, this is for reappointment for Division Chair of Neonatology.
Thank you. Any questions, comments? All right. Great. Thank you, doctors. Motion to approve item 3A of the two proposed Georgia Hospital Division Chair reappointments.
Second.
Motion's been made and seconded. Any discussion on the motion? All those in favor say aye.
Aye.
All opposed, say nay. Ayes have it, motion carries. And we'll go to our executive medical staff, Stroger Hospital Medical Executive Committee of Providence Hospital reports and action items presented by Dr.
Alter.
Thanks
for having me. The summary from the HQPS meeting include the radiology quality improvement, imaging access. The Stroger's MRI average wait time was 49 days, the target being 50 days. CT average wait time was 52 days, target being 50 as well. Wait time challenges, there's been significant barriers, including limited scheduling of staff, only one schedule currently for MRI, CT, and ultrasound, and a minimum of 14 business day requirements for the prior authorization. In terms of volume trends, the MRI outpatient volume has increased substantially over the past year. In 2024, there was 2,834 outpatient MRIs, and in 2025, year-to-date, we're at 4,040. For the utilization and care management component, denials, inpatient denial, positive outcomes are currently meeting the 80% benchmark. For social work documentation, seen within 2 days of documentation is tracked across all medical firms, and the current averages range from 1.9 to 4.1 days. In terms of falls, there have been 18 falls year to date with 8 injuries, which is on track to meet the goal of less than 24. There's no action items for the QPS committee.
Any questions, comments? All right, thank you. So Dr. Paul Allegretti.
Hi, good morning, everybody. I'm on remotely.
Good morning.
The appointments and reappointments for Providence Hospital were approved by the Centralized Credentialing Committee and then approved by MedExec on January 14th. And I'm asking for your approval for the appointments and reappointments for the providers at Providence Hospital.
Thank you. Any questions? The motion to approve item 3B of the proposed Georgia Hospital Providence Hospital medical staff appointments, reappointments, changes. Motion been made and seconded. Any discussion on the motion? All in favor say aye.
Aye.
All opposed say nay. Ayes have it. Motion carries. We'll go to the minutes of the December 12th, 2025 QPS Committee Meeting. These were approved by the board at the December meeting. Asking if directors have any corrections that are needed or the team. All right. Motion to accept item 3C, Quality and Patient Safety Committee Meeting minutes of December 12th, 2025.
Second.
Motion's been made and seconded. Any discussion on the motion? All in favor of the motion say aye.
Aye.
All opposed say nay. Ayes have it. Motion passes. We'll go to item 4, Operational Excellence Dashboard, Goals and Tactics. Start with Stroger Hospital Site Review. Donna Costa, Thank you.
Okay, good morning, everyone. Donica Austin Cathy, Chief Hospital Executive for Stroger. Thank you for the opportunity to share the Stroger OPEC Committee dashboard. So before you today, so kind of giving a little background, we have 2 of our metrics that are currently meeting the stretch goal, our patient experience in nursing and our post-hospital readmission. We have 4 metrics that are currently meeting the target in physician-patient experience, our COPD readmission rate, our work in our throughput and our geometric length of stay, and the ED length of stay for ED discharged patients. And then we have 3 metrics that we still have opportunity improvement that includes the mortality index, the sepsis bundle compliance, and our PSI 90. Next slide, please. Next slide. Okay. All righty. Looking at our dashboard, first we begin with our patient experience. Currently, we see there's been improvement. We have met the target for 2025. The target was 85. The measure improved 2.3% change in our top box points. And for December of 2025, our metric was at 88.69 at the stretch. So we came in very strong on the provider communication. I do want to note that there's been a lot of work with our physicians, Dr. Coley and Dr. Elenis. They have been working on continuous education with the teams. They're focused on pediatric medicine, family medicine, improving the communication as well as overall education for our residents. And they also are piloting on 8 West, where they are, just looking at the specifics of just in-depth education on the unit, not only with nurses, but then with the physicians to see if that will continue to move the scores. Specifically looking at how people understand when a doctor explains maybe their discharge paperwork. So moving into nursing communication, we have seen improvement and met the stretch goal for 2025. The measure improved 5.9% in the top box points. For December, we were at 82.02, above the stretch, where we came in at the year end of 76.07. So we're still continuing to make some improvements in nursing. They continue to do their training on compassionate connected care. They're doing their hourly rounding, the eye rounds. Those are being audited by a team. They are also focused on the whiteboard, so whiteboard compliance and, introducing themselves and their names. And also looking at the environment of care. So again, a lot of really great work in our nursing communication. Moving to our clinical outcomes, looking at our mortality index, we came in under the 1.0 index. which is good, but we're not quite at the goal of 0.8. So a lot of work is being done with the team related to mortality. As I spoke about at the last meeting, the team included nursing representation, and they're doing the case reviews. They're also working with the medical and surgical committees and looking at the documentation and capturing things like the palliative care coding, as well as the present on admission for ventilator patients. Going down into our patient safety indicator, PSI, is not quite meeting the goal for 2025, the January through November. We have one more remaining month because this is one of those lagging metrics that we get. So currently for November, we were at 1.05. In January, we're coming in, January through November, coming in at 1.09. Again, the target is 0.9. Moving to sepsis, the SEP 1 bundle compliance, there's been gradual improvement in this metric, but consistently below the goal, which is 67%. And our baseline is at 56%. So for November, we came in at 55%, and from January through November, we're currently at 44%. So the team has been, they have moved forward with a power plan for sepsis, and they are also working on education for medicine and family medicine, and also working with our residents and training them, and again, it goes back to documentation. Next slide.
So you're saying documentation is one of the issues on this last measure?
Yes.
Anything else that the team's working on?
I know there's work, again, on the, not only the documentation, but the resident orientation. Anything else that we're thinking on the sepsis?
And curious about PSI 92.
So a lot of this is kind of, as we do review the cases, we uncover kind of one issue, for example, you need to document not to give fluids. And then as we fix that issue and kind of do education around that and kind of fix that issue, we uncover that, okay, you need to not only document you're not giving fluids, but then also document an alternative goal. So it kind of becomes like peeling back a layer of onions in that sense. So as we continue to educate and then review with the Q-centric group and understand where the fallout is focused, we kind of augment our education ongoingly. Currently, some of the focus is including a sepsis-focused quality improvement rotation for the EM PTY2 residents, as they kind of primarily are in the ER, which is a new thing we started this year. And so I'm hoping that as we kind of build that out year upon year, it'll be more common vernacular to how to appropriately document, including also ongoing resident education conferences and faculty presentation. New for this kind of academic year, starting last July too, we also started presenting our sepsis performance bundles along with specific recommendations on how to augment your documentation on a monthly basis for both faculty and for residents. So they're getting this data more often, and they're getting suggestions on how to improve their documentation based off our monthly or weekly reviews at this point.
And I guess in addition to what Dr. Palter shared, sort of from the physician perspective, our sepsis coordinator is doing in-depth coaching with our nursing team to help understand some of the barriers related to their parts of the process. And going live very soon, we now have an electronic process to document blood culture collection. And that was a multidisciplinary partnership across the organization that will now sort of take that from a manual process and something our nurses have to remember to do to an electronic process. So that'll be a huge win.
I have a general question about deciding your goals. Sounded like from the goals are changing, like your first documentation, and then you realize, oh, you have to do like this additional documentation. I wonder why that is, because, I would think that you already have like standards, right? So you have to do these things, you know what you need to do going in. Or is it something that you just have to discover after you practice? I'm just curious about that. And I wonder, like, part of it is because, we're setting goals, but is it like maximum goal that we can achieve? Or like you said, documentation flow culture, like you have to go to like, automated documentation. So I'm just curious, like, how do you set a goal and how do you know it's training and or person issue, or you totally have to do systems level change?
Yeah, before you respond, just when you're coming up to the podium, just please identify yourself. Thank you.
I'm Andrea Rammel, one of the directors of quality improvement. The CMS document related to sepsis specifications is over 500 pages. And that's one of the valuable pieces of our partnership with Qcentrics that Dr. Palter mentioned, is their intricate knowledge of that document. And also, as we abstract our sepsis data, it's abstracted up to the point of failure, right? So we know that there are 3-hour components and 6-hour components, but once you fail on one component, the abstraction stops. And so part of this is we've gotten so much better at meeting the upfront parts of the bundle, and so now we're continuing to learn where our opportunities are downstream. And I think you raise a good point, which is something our group has talked about, where when we're partnering with Qcentrics, we want to make sure we're asking really good questions, because they let us know that the way we were documenting not giving a patient fluid was not, didn't meet the guidelines. And so we adjusted. And once we adjusted, they came back and said, okay, now you need to fix this. So we've learned that we need to ask more questions so that we fully understand all of the pieces and not sort of assume that they're going to give that to us.
This is Dr. Palter again from the emergency department. One such example of that is we created the power plan, and we've been kind of following along to see how it's been impacting performance. And then as we identified new issues, we altered the power plan again to address the new deficiencies that we're meeting to assist our providers in providing the appropriate documentation. So not only are we changing it as we go, but then we're also changing the education around it in real time so that we can address our deficiencies. And I think that's why we're hopefully going to continue to see that gradual improvement as we continue to adjust our approach and change our tools to meet the needs of our providers to better document the issue.
Thank you.
Thank you.
Okay. Moving to the next slide, readmission. Okay. Currently in our COPD rate, the data shows that through October of 2025, we have met the stretch goal of 14. We still have 2 additional months of reportable data to round out the year, but again, we're moving, obviously in the right direction. And for the month close, we're meeting the stretch, and year to date, exceeding the target. Also, moving to our post-hospital follow-up days, we see that we also have seen improvement and have met the stretch goal of 20 days. This is for the decreasing our monthly post-hospital appointment days for adults. This measure did reduce the average days post-hospital follow-up by over 40%. In December, we came in at 14.6, and, we came in at the year end of 14.60, which again exceeds the stretch goal. Moving to our throughput, the two metrics that we had here, decreasing our geometric mean length of stay and decreasing the 12-month median ED length of stay for ED discharge patients. For the geometric length of stay, we've seen we're meeting the goal thus far through November of 2025. We've seen a 23% reduction in the change year over year. In November, we were the month we were at 1.57, which is better than our baseline, which was 1.87. And then for our ED length of stay for ED discharge patients, we've seen again improvement in meeting the goal thus far for 2025. We do have one more month remaining. We've seen a 5% reduction in year over year in our ED length of stay. For the month, we were at 233 minutes, beating our stretch. In year-to-date January through November, we were coming in at 294 minutes, still, again, meeting that, or beating that target.
Good to see the continued work and the results on this. Thank you.
I have a quick
Question?
about COPD. Looking at the goals, July, August, September, there's like this, drastic change between July to August, and then all of a sudden August to September. It makes me wonder the issues, the reason that COPD readmission rate is going up and down like that might be not necessarily like really something that you can't change. It seems like it's just fluctuating, meaning that you can easily fix it. What do you think?
Well, a few things are taking place behind the scenes with the team on this. They are focused on the pulmonary rehab referral rates and trying to get those up and increasing the quit aid for those patients that are prescribed at discharge. Also, there is a new order set, and they're continuing to educate around that and making sure that there's not only a referral to the pulmonary clinic, but then there's the lung health educator. So being consistent every single time with those patients.
Okay. Thank you. We're done. Anything else you want to share?
Thank
Go
you.
to Providence Hospital Site Review, Dr. Turner.
Good morning, directors. Dr. Arnold F. Turner, Chief Hospital Executive, Providence Hospital, Cook County.
Good morning.
Before you have the 6 focus points for Providence Hospital. We have 2 metrics that are meeting the stretch goal, 2 that are meeting the target, 1 that's greater than the previous baseline, and 1 that's not better than the previous baseline. Next slide, please. Go in a little more detail. Okay. The 1 metric that's been a challenge has been the survey return volume. Our volumes historically have not been at target, and we're still well below that again this quarter. The measure will not meet our target for 2025. We put in a lot of effort in this as far as even calling the patients, when the nurses make their rounds there, and at discharge, both the nurses and physicians stress the importance and the value that we get from receiving their feedback through the survey, but it just doesn't seem to be making a difference the survey is a mail survey. I know coming, we're supposed to be switching it over to electronic survey, which will be emailed to the patients, and hopefully that will have a greater impact on our return, because that's valuable information that we need as far as what is their perception of the services that we're giving them, so that we can make any improvements. With the small volume, it's hard to make anything out of that, but the good thing is that even with the small volume, we still get some positive feedback on the services that we get. The next metric is nursing communications. This metric has met the goal for 2025, coming in at 80. The top box, 80%, 80.80 to be exact. December came in at 50% top box, but we only had 2 surveys. Again, small volume return. Thus, outcome is volatile until we sustain measurable return surveys. The next metric is sepsis. From January through November, we were better than the baseline, but we have 1 month to go for the year-end performance. November came in at 100%, and January through November coming in at 50%, which is better than the baseline. Falls is one of our metrics that we met the stretch goal. This metric was the stretch goal was 12 falls for the year. We met that. Last year in 2024, in January, I think we had 32 falls, and for the entire year for 2025, we had 12. That goes to the great work that our nursing department and efforts that they put in and things they put in place to make sure that we attain this goal. The next one is the ED decision to admit to depart time. This is the other target that we met the stretch goal. The stretch goal was less than 100 minutes. We came in at 99 for the year, and again, that's due to the outstanding work that Dr. Paula Gray, the director of that of ED medicine at Providence, and the nurse manager Amy O'Malley put in a lot of efforts there. Kudos to them. And the last metric is left without being seen, which we've had a lot of success with that. We are better than the target and almost hit the stretch goal of being less than 1%. We were at 1.03% for the year, but the last 3 months, we have been below 1%. Any questions?
Any questions, directors, comments? I appreciate the perspective on the electronic survey. I think, with some of these, it's, if we do the same things over time and don't get different results, then it's important to review, and what can we do differently. So we'll look forward to hearing how that goes. Thank you.
Chair Bott, for the record, Pat Merriweather is remotely connected.
Okay, thank you. Thanks, Pat. Any questions or comments from me?
Just, and again, I don't want to go backwards, but I just felt that maybe there could be some social media around sepsis and the symptoms. Again, I know the bundle is a little bit lower than last year, but it seems like we're catching up a little bit. But I just feel that so many lives can be saved by doing something on social media. And I would take a patient that had sepsis and let them share what were the symptoms and things that they maybe didn't see or know, but what everyone should know. Again, it's just an idea.
Thank you, Pat. All right, we'll go with ACH site review. Craig Williams.
Morning, Directors. Craig Williams, Chief Operating Officer. I'm going to report on our performance at ACHN, which is our ambulatory care network. First 3 measures are focused on patient experience. First one is the measurement of how well our staff works together. We've showed gradual improvement throughout the year, but we've been consistently below target, but we are better than baseline in prior year. We didn't meet the goal, but we did improve 3.7% change in top box scores. In December of 2025, we're at 69.18, which is that goal, and we came in year end at 67.27% top box. This is a metric we'll remain working on and is a key focus of our patient experience team, and kind of prepping the patient throughout the entire journey so that we're talking up the next level of staff at each interaction. For our provider scores, on provider addresses concerns, worries, we showed gradual improvement. We're consistently below target, but better than baseline. While the measure did not meet the goal, we did improve 2.2% across our top box scores. And for December, we're at 65.82, which is that goal, and we came in at year end at 67.27 top box. On provider explains problem condition, we had improvement and met goal for 2026. We did improve 2.9% in top box scores. And in December, we're at 58.68, which is that stretch. We came in the year end at 67.27 with top box. So, I think still some work to do on patient experience. The provider scores have shown improvement. I think we've shown improvement across everything, but we still have a little bit of work to go to get to where we want to be. Within our HEDIS scores on breast cancer screening, we had improvement throughout the year. We met the stretch for 2026. It's one of those charts that you like to see where we see that gradual improvement throughout the year and well above target. And we improved 26% in screenings for the year. In December of 2025, we're at almost 64% breast cancer screening completed. On hypertension management, we showed improvement throughout the year and met goal for 2026. The measure improved by almost 11% in patient outcomes for high blood pressure under management to less than 140/80. In December 2025, we're at 58.4. Across these two HEDIS measures, we're working with the team to make sure that not only are we continue to maintain the levels that we have on these scores, but also look at other places across payer contracts that we need to improve to capture potentially more revenue. And then the last goal was around our empanelment of patients, and we defined that as patients attributed to us, meaning they've been seen at least one time in the last 2 years, or engaged, actually that's talking a little bit, so this year was one time in the last 2 years. We did show gradual improvement, but we didn't meet goal for 2026. We had a 1.1% change in a panel of patients, resulting in about 1,200 new patients engaged or attributed. So part of this is being able to bring in new patients and then also ensuring that patients don't fall off the backside, I guess, as I think about it. They've gone over 2 years without being seen. Inherent in this data is a lot of the new arrival patient population, and we know that that's a population we've had difficulty retaining in our panels, just in terms of how they're staying in the city or have gone to other places. So we continue to study that. For next year, we'll have a new attribution model that's going into place that will use the payer eligibility files to better align with both including APPs in the metric, but just overall how we're measuring attribution and aligning with the payers. So I think we'll continue to see some changes in this and some fine tuning of how we measure our overall empanelment.
Thank you. Any questions?
I'm just curious regarding patient experience. Do you see, differences, variance among clinics?
We do. We see a little bit better engagement in our medical homes, which, in some ways makes sense. Those patients are familiar with the providers or having repeat visits there. And we see a little bit lower scores kind of in our more hospital-based specialty clinics. One of the things that we think is a little bit of a dissatisfier right now is kind of the focus of the front desk clerks and kind of managing the waiting room experience and giving people heads up on wait times. You know, we also, many of you may know, when you walk into the professional building, we have kiosks, and the process is for the patient to quote unquote check in on that kiosk and then go up to their clinic and wait until their number's called. We've been really looking at that kiosk process because it's really a glorified deli ticket counter, right? It's not integrated with our EMR. So if you show up early for your appointment or you show up late for your appointment, you're still in the same queue with no prioritization. And so it's created some issues and flow in the practice. So I'm inclined to just throw it out. My team sees some benefits of it, and so we're kind of in negotiations right now around how we get to the final place on that. But, you know, that's another factor. We don't have that same sort of ticketing system in the medical homes, and I think we just perform better there. Sure.
Thank you.
Thank you.
All right, we'll go to our report on other quality and patient safety matters with regulatory update reviewed by Director of Quality and Regulatory.
Good morning, Joseph Finance Director of Accreditation and Regulatory. Provide a status of some current visits and upcoming surveys. We had an unannounced IDPH investigation focused on emergency services at Stroger. 2-day visit, Tuesday and Wednesday, December 23rd and 24th, just before the holidays. Preliminary report was we had no findings. We're expecting a final report any day now. So we'll be able to give an update on that in the next meeting. IDPH outpatient dialysis recertification survey. This is take place at Stroger. It's expected any time. We've been in the window now for over a year, so one of these days they will walk through the door. IDPH EMS Resource Hospital site visit also at Stroger. We're expecting spring of 2026. We have the National Commission on Correctional Health Care for CIRMAC, some mental health accreditation. We are applying for the accreditation with a goal of a 2026 survey, and they're right now evaluating whether they can do a joint mental health or a juvenile temporary detention center survey together. Also, with the National Commission on Correctional Health Care for CIRMAC, we are looking at jail accreditation expected in 2026, and we were alerted it'll be sometime second quarter or later. We have American College of Surgeons, the Cancer Registry Team for Stroger, Commission on Cancer. We are looking at a virtual site visit. We do have a date scheduled for April 21st, 2026. And lastly, as far as upcoming, we have IDPH perinatal redesignation at Stroger. We're anticipating that in fall of 2026. So a busy year. Next slide, please. One of the things that's happening in 2026, we're in the Joint Commission triennial window at Provident. It's an unannounced visit. We did have the last survey December 5th through 8th of 2023, so 3 years ago. So we're expecting it again. It's unannounced sometime between June and December 2026. So as far as prep work, some examples of things we're doing. A deep dive was completed at Provident, started in the units in September through November. We have a weekly multidisciplinary team rounds that started first week of December and will continue until the site visit. Tracers are supposed to have their start mid-January. Actually, they will start next week. We're going to be tracing patients through levels of care, not only working with staff, but looking at any type of gaps in documentation in the EMR. And we're planning, preliminary planning of a mock survey to take place that will align with the survey process guide, which is new for 2026 from the Joint Commission, over 2 days, likely in April of 2026. In enough time so that they were to come, let's say, early in June, we'd be able to put together corrective action plans on any deficiencies and then try to close those gaps. Next slide, please. And I want to share with the group some of the findings we found during the deep dive rounds. I just put top 6 here, walk through them with you. Expired products was multiple findings in that. Some, as far as environmental, dusty sprinkler pendant heads, ceilings, expired wall gel for hand hygiene. I did find some expired PM labels of preventive maintenance on the equipment, logs in the crash cart, eye washer temps, whether there was gaps in documentation and or previous months. Made a note of that. And then again, as far as visual and environment, dust buildup in the vents. As far as action plans, a lot of these things, as you might imagine, we were able to take care of right on the spot. We, of course, alert to them. I mentioned here expirables, taken care of right on the spot, and we're able to do that. But you'll find that as far as wall hand gel, when the area has less volume, because usually you would go through that pretty quickly, but if it's got less volume, it may sit there for a while. A lot of people don't look at that. Findings we discussed during our weekly rounds and through reports, we've organized all this to be assigned to owners to provide status on. I'm working on that currently. It looks like I'm going to be using a tool called Accreditation Manager Plus, or AMP, after a meeting earlier this week, which seems to be a good piece of software in order to organize all this. And then we can follow up, provide it in our provident bi-weekly meeting. That's it.
Please, has there been discussion about proactive system to sustain standards and so that we minimize how much of this may happen in the future?
Can you do a little?
So like this seems, I guess maybe say is reactive in terms of the action plan. Or was there discussion about how to be proactive so that things don't happen?
Absolutely. The whole point when I get this stuff put into AMP, I think if we can come full circle. Like, alerting to it is one thing. If I go through and make things up in the next month, find the same thing, then you're right. There hasn't been any type of corrective action. So I'm hoping to educate staff into looking at this. Maybe they, as far as expirables, obviously, they can delegate it out to staff members to look at the end of every month. So when they start a new month, things will be pulled. But I think hopefully in my next meeting, I'll have more information on that as I get this Accreditation Manager Plus tool loaded with some of these findings, and then able to make assignments for accountability and come full circle. So that's the plan. And that these things should, whittle down and be corrected.
And are there plans for super users or those that are well equipped with the tool to train others?
There are people that are very familiar with AMP right now. I'm getting up to speed with these capabilities. But what's nice about it, from what I'm to understand, is once I put in an owner, it'll shoot out an alert that this is the finding, and I can then provide them with a report. A lot of times what I'll do is I'll take pictures and I can attach them within the actual report so they can see exactly the location, and then like if it's preventive maintenance for a PM label, they can go in and correct that on the spot. So again, there'll be some accountability, there'll be assignments. And as far as users, I'll be kind of the main user as far as that software, sending out the reports, but there'll be a lot of people are getting trained on how to read these reports and stuff. It's happening with our ambulatory clinics. It's just a question of just transitioning it on.
Thank you.
Certainly.
Any questions, Tom?
Can I just ask a quick question about, you mentioned, cancer registry is one of the things that's coming up, right?
Yes.
But what are the things that, that's required? Is it just a simply cases?
Well, yes. So this is going to be the virtual visit that's scheduled April 21st. And then what I could do is I can also bring some more information to the next meeting that we have here to provide some on that. But they'll be looking at cases. They've got an agenda that I need to get a look at, just to become familiar as well. And of course, we'll have the command center set up for support and anything that they need. So, but I'd be happy to give an update on that next month too. There'll be more information.
Thank you.
And Pat,
Comment? Yeah, Pat, go ahead.
Okay. I don't know if, does the MAT program for the medication assisted, therapy, there was a surprise issue by SAMHSA this week, and I'm sure you probably heard about it when all of a sudden one evening, a Tuesday evening, 2,100 organizations were notified that they no longer had SAMHSA funding. And it sent an uproar. And actually some centers had to close down that next morning. So I'm just wondering, I know we've got the MAT program just starting off. And is there any type of regulatory oversight or anything that we can have an update on later on? Because I truly believe, Stroger is well positioned. Cook County is well positioned to have a program of that magnitude.
Dr. Merriweather, in terms of the area for substance use, is it medication-assisted treatment or something else?
Yes, it was the MAT, the medication-assisted treatment, also giving out, the Narcan and the different, it was huge. It was a $2 billion cut that they put in place. And then the next evening, they had to put it back because it was a bipartisan outrage by it.
Yeah, so as it pertains to the SAMHSA cuts, we were briefly impacted, as you point out, Director
Oh.
Merriweather. It was rescinded the following day within 24
Right.
hours. Impact to us would have been annualized about $500,000 and directly impacting our bridge clinic. There were 3 employees who were funded through the SAMHSA grant that we had lost for 24 hours. And the bridge clinic funding would have been also impacted. We're happy that it was brought back.
Right.
And we obviously were scrambling during that day to figure out how we continue to fund that work. We were looking at there's an opioid settlement fund that we were looking to continue that work through. And just a bit about the bridge clinic, some really incredible work. Back in 2023, we looked at some numbers, and it was almost 70% of the patients coming through the bridge clinic were abstaining from drugs and alcohol for an entire 6 months while they were in treatment. And I believe it was a 60-some% reduction in arrests, and 22% had engaged in gainful employment while they were in treatment. So, it really shows that clinics like that really do work. And the fact that there was even a consideration to defund that type of work was somewhat mind-boggling.
It was. So I'm really happy that, Cook County is engaged and involved in that, because no one knows our future in terms of any more cuts like that. But thank you.
Any other comments, questions? Oh, did you want to, if you just identify?
I just wanted to comment on one of the questions that Director Cross asked about what are we doing proactively. In addition, we have created rounding tools for the site leaders to also participate in regulatory compliance. And we're rounding with them regularly just to make sure they understand what the expectations are, but creating also tools so that they can also independently round and reinforce what we expect during rounding. And so we're working with them more closely on that, and just checking in with the leaders, and also just alerting them to the upcoming changes with the Joint Commission 360 new process that have been updated.
Thank you, Irene. All right, thank you. Committee will not be going into closed session today, so see if there are any other questions or comments from the directors. Okay, can move to adjournment of the meeting. Motion, as the agenda is exhausted, meeting's adjourned.